Good evening, everyone. A very warm welcome to all of you to Oncology Classroom evening session. And in continuation with our mixed bag classes in the last month, today's talk will be on an overview on management of pituitary adenoma. So definitely it's going to be almost a pure radiation oncology topic. And I do not expect many people to join in this discussion because it's not a mixed topic. So today's speaker is a very well-known teacher on this forum, Dr. Abhishek Chatterjee, who is assistant professor in the Department of Radiation Oncology at Tata Memorial Hospital, Mumbai. And Dr. Chatterjee is associated with neuro-oncology, and he has been dedicatedly practicing neuro-oncology for quite some time now. And has also, if you have read his article, he has published articles on pituitary adenoma management, and it's a very fantastic article to read. Dr. Abhishek has multiple peer-reviewed publications to his credit till now, and it's a real pleasure to listen to him, who always tries to keep this lecture brief, crisp, and to the point. And most importantly, he always tries to make it very simplified for the residents. So thank you, Dr. Abhishek, for again accepting this proposal. And I know within in a very hectic working day, you agreed to do this. So without wasting any further time now, I would stop sharing the screen from my end. And I'd like you to share your screen and start the presentation.
So, am I audible?
Yes, you are audible, and
my slides are visible. Yeah. Okay. Great. Good evening, everyone. I will restrict myself to radiotherapy for pituitary adenoma because management per se is quite complicated and multidisciplinary, and would only confuse people. It's not such a common histology one sees in the OPD, but one does see enough to necessitate knowing what to do correctly. So, if the first thing that we talk about is the fact that if you notice, pituitary is a completely separate classification under WHO, and this classification came out a year after the WHO 2016 classification on brain tumors. The thing is, this classification was mainly done by endocrine pathologists, and unfortunately, as a consequence, the oncology perspective on it is lacking, which is very evident in this slide. So you will see that it is lineage-based classification based on immunohistochemistry. In the absence of immunohistochemistry, transcription factor analysis needs to be done. But due cognizance has also been paid to certain histological subtypes, which are seen in the middle, such as the sparsely granulated variant, the lactotroph, the Crook cell, which are at a higher risk of recurrence. So overall, this is quite a complicated classification and not really intuitive. For us, therefore, it is important to keep it very simple. For us, it still remains non-functional and secretory. And our aims are very clear. In non-functional adenomas, we basically try to intervene in the event of regrowth, which happens in almost 60% of adenomas treated with surgery alone, especially in the presence of Gros disease and paracellular and cavernous sinus invasion. Progression of the residual can happen in up to as much as 30% of patients otherwise. And the aim is growth arrest. This needs to be made very clear to the patient that the tumor is never going to go away. And therefore, he or she must maintain a diligent follow-up. The secretory adenoma, on the other hand, basically we treat it in the event of biochemical relapse, which is common, in the event of failure of medical therapy, which is common, and in the setting of radiological relapse, which is rare because classical textbook teaching teaches us that these adenomas are usually microadenomas. That, however, is not true when you sit in the clinic in India. It is very common to find people who have sat and neglected Cushing's and acromegaly symptoms for years to come with large tumors. Now, the aim here is twofold. It is growth arrest as well as biochemical remission. In addition to this, certain histologies such as the sparsely granular variant and the Crook cell require treatment on account of their increased inherent potential for relapse. Fourthly, there is a case for direct RT in the elderly and in the setting of inoperable disease, especially in the setting of visual compromise, which is setting in very fast. Interestingly, if you look from top to bottom, actually radiation efficacy drops. That's another thing which one should remember. The radiotherapy workflow for pituitary adenoma is very standard. It follows very standard guidelines and principles. Now, when we come to the modalities, typically there are two modalities. One is conventional fractionation, 45 gray to 25 fractions. Historical doses of 50 gray or more have been used and don't really hold much gravity in the current era. On the other hand, is stereotactic radiosurgery, which is typically used for small lateralized adenomas which are more than 3 millimeters away from the optic chiasm. It may either be single fraction radiosurgery, classically delivered through gamma knife. What is coming into vogue lately is fractionated radiosurgery. Now, when we come to look at outcomes, and if we look at the table of these few selected studies for conventional, for non-functional pituitary adenomas, we can see that the 10 and 20-year controls are quite good, irrespective of the modality of treatment that you use. If you do gamma knife based radiosurgery, actually you can, the doses also, if you see, are on the lower side. You easily deliver doses between 18 to 20 gray, get very high rates of local control. For LINAC based radiosurgery, typically the doses delivered are lesser as the degree of conformality is less, and the inherent precision of the gamma knife immobilization system is also more. So typically what we remember for non-functioning pituitary adenomas is the 10-year control is 90%. Okay. And the hypopit, if you typically see, it varies anywhere between 20 to 30% at 10 years. 1 out of 3 patients will become hypopit. Now, when we come to secretory adenomas, irrespective of the histology, we should remember two big figures. One is that the local control of the tumor will remain in the 90s, but the biochemical control is as low as the 50s. So typically, if we look at Cushing's, again, if we see, our local controls are good, but the biochemical controls are not good. Typically, by the time we reach 5 years, biochemical control falls away to the 50s. Despite delivering higher doses of treatment through single fraction SRS, as we acknowledge these tumors to be more resistant. Also, coming to growth hormone secreting adenomas, the picture is somewhat similar. You have control in the 40s to 50s when it comes to biochemical relapse, and in anywhere between the 70s to the 90s when it comes to local control of the tumor per se radiologically. The third entity, prolactinoma, is not typically encountered in the clinic because prolactinomas typically are extremely sensitive to medical therapy. However, the prolactinoma which does progress on medical therapy and is referred to you in the clinic is usually a pretty aggressive entity. It will be a macroadenoma most of the time. It will be very invasive, and typically these have a very adverse molecular signature, as has been elucidated in recent literature. So if you see, the controls actually are even lesser than Cushing's and acromegaly. So at face value, it may seem that prolactinoma is the most resistant histology. That is not true. This is a classic retrospective bias, whereby the worst patients have received radiation. That is one thing which we should remember. And across all these series, you will see hypopit is 20 to 30%. Hypopit is usually lesser with gamma knife when we do it for lateralized lesions. Now, typically, since SRS is pretty interesting in this scenario, historically what has been done is lesion alone SRS or partial cella SRS in the side on which the tumor has been localized by other modalities, let's say inferior petrosal sinus sampling. It gives very good control in NFPA, but secretory, what it achieves is a very steep fall, a very steep initial fall of the hormones, which may actually give rise to much better control of the secondary morbidities encountered in these tumors, such as hypertension, diabetes, weight gain, edema, which are extremely troublesome for patients. But at the end, what we typically see is, despite much higher doses, similar biochemical control. So this slide elucidates the high rates of local control in a recent systematic review, which is in the 90s and is maintained in the 80s at 10 years. However, when we come to secretory adenomas, typically what we are seeing is that the endocrine remission rates are actually less than 50%, like we were seeing in those earlier papers. Now, this makes us think on several lines. So our personal experience with local control rates actually in secretory tumors, though the data is of a lesser number of patients, they exceed 60%. Now, what has also been understood historically is that particularly in secretory adenomas, there are multiple microscopic cell rests in the entire cella. You may give 25 gram with gamma knife to one part, but you may completely end up not treating. And this probably negates the degree of biological control. So the solution would be to treat the whole cella with hypofractionated radiosurgery, which may seem to be a very counterintuitive terms because our typical dogmatic definitions assure us that radiosurgery should be 1 to 5 fractions, more than 8 fractions. But frankly, it is a matter of semantics. Radiosurgery today is a function of precision, not of dose. And that must be clearly understood. So the thing is, if we see on the right side, we will typically see that there is emerging evidence for hypofractionated radiation showing equivalent good short-term control rates. This, coupled with the increasing experience with fractionated SRS with safe doses from 25 grain 5 fractions to 21 grain 3 fractions, proposes it as a appealing and interesting candidate to sort of get the best of both worlds: shorter treatment for patients with equivalent rates of local control while achieving the steep hormonal falls seen in SRS. And this is something which is interesting and which we are exploring. More on that will probably be more evident in the future. So when we come to principles, if we talk about contouring, for secretory adenomas, typically they are microadenomas. So usually there is no GTV. We include the entire cella and treat with a margin anywhere between 3 to 5 millimeters, depending on the degree of image guidance and precision you have. For non-functioning pituitary adenomas, typically there is gross disease left behind which has progressed, which we treat. There is usually no need to treat a stable residual in a non-functioning pituitary adenoma which is not causing any symptoms. Typically, even though these are benign tumors, for covering uncertainties in post-operative setting, areas of microscopic spread which are not very easily visible at air tissue interfaces in the cella, what we usually do is we give a 3 to 5 millimeter CTV and we respect anatomical barriers. Right. Now, and one more thing which we typically do when we are considering more hypofractionated, usually there is nothing to worry about in plan evaluation in these tumors, rather than it's a pretty easy plan to approve. What we have been doing over time is increasingly, but however, when we are dealing with hypofractionated settings, what we usually try to do is curtail the full dose going to the optic chiasm so that we are safer than safe. Because this is we are still learning and exploring about this. Now, this particular figure shows us the historical evolution of the techniques and the conformality. This is a typical bilateral. You see, while that tumor bed is very well covered, a larger part of the medial part of the temporal lobes and the hippocampal heads are treated to a higher dose. As we evolve from a 2-field to a 3-field, so classically what we used to use in TMH with 2 collimated laterals and 2 vertex beams, you keep on achieving increasing conformality of the higher dose volume while reducing the high dose spill to the rest of the brain. And when you start using IMRT, typically you are able to constrain the doses to structures such as the hippocampus, which have important implications for cognition. We have published our experience and shared it at Astro earlier, and we typically try to reduce our hippocampal doses to between 12 to 16 gray, and of late we have been able to achieve even lesser than that in many cases. So that is also work in progress. Another important thing which we need to remember is to stop medical therapy such as cabergoline, ketoconazole, all of these drugs, basically cytostatic agents, prior to starting radiation, preferably anywhere between 4 to 12 months prior. And once the radiation is done, if there is a failure of remission, we can always consider to restart it. The role of supplementing the remission achieved by radiation with additional medical therapy is actually quite unclear. Now, last but not the least, we need to remember that radiation should always be avoided as much as possible in patients of pituitary adenomas. Only when clear indications exist should we treat, and without undue recourse to extreme hypofractionation, because conventional fractionation is very safe and gives excellent results. These are young patients who will have to live with the lifetime consequences of radiation, and it is not a nice thing, as it is for a lot of these patients with secretory tumors. It's life is frankly drawn out torture with the severe metabolic consequences of these tumors. And on top of that, if you add your radiation induced toxicity, it is not particularly great. So touching upon the main late toxicities, hypopituitarism, which goes up to as high as 60% at 10 years, higher with radiosurgery. Typical figure is 30 to 40%. Should always be managed in conjunction with an experienced endocrinologist. What we typically do is we always work with endocrinologists and ophthalmologists while taking care of these tumors. The neurocognitive decline, 15 to 60%, affects quality of life in 25 to 40% of patients and may reduce return to work and reintegration in society. You have to remember all of these are very young individuals with a lot of hopes and aspirations in life. There is a historical description of increased cerebrovascular accidents, possibly due to irradiation of the bilateral internal carotid arteries, referring to Mike Brada's seminal work on this issue, which actually showed a relative risk of more than 4 for CVA. This has not been substantiated to the similar extent in later work, where other risk factors such as coexistent hypertension, diabetes have been found to be equal contributors. However, this is something which we need to pay due cognizance to, and while evaluating the plans, it's always good to avoid hotspots on large vessels. Second, primary malignancies can never be ignored. The incidence is 2% at 20 years, which may sound low, but the fact of the matter is all of these are probably avoidable malignancies. The relative risk is highest for meningiomas, which almost reaches 24, and typically these radiation-induced meningiomas tend to be very bad meningiomas, lots of very weird genetic alterations, and don't really respond very well to any sort of therapy. The gliomas which typically occur are high-grade gliomas. Last but not the least, conventional radiotherapy associated optic neuropathy is very less than 1%. And if you are treating with radiosurgery and keeping your optic nerve dose to less than 12 gray, your optic neuropathy is less than 5%. So that is a brief overview of pituitary adenoma radiotherapy. And we are learning much ourselves as we explore it more and more. And with that, I would actually like to conclude and take a few questions. Thank you.
Thank you, Dr. Abhishek, for your another crisp and to the point presentation, which is a signature to you. And I would now like to invite questions from the listeners. You can put your questions on the chat box. So the first question is any role of re-radiation?
Best avoided. Best avoided, because you see, most of the time the re-radiation is not really necessary, because if it hasn't worked the first time, it's unlikely that it will work for the second time, and you really need to be careful about your optic nerve doses. Of course, if everybody throws up their hands and the patient is developing significant optic compromise or has significant hormonal derangement, we may decide to re-radiate on a case-by-case basis, but it's something which we rarely do.
So putting this question in a different way, who are the candidates where you would consider for re-radiation?
That's what I said. If everybody throws up their hands and the patient is developing very rapid, incipient optic compromise, because see, the thing is, most of the Cushing's and all secretaries will mostly progress within a short time, the ones which progress, okay, and it becomes difficult to re-radiate them anyways. So typically the re-radiation scenario arises when we get these small central recurrences, okay? And we have this fantastic place across the road called KEM with a fantastic neurosurgery department, in addition to our own extremely good neurosurgery department. I mentioned KEM first because they have a larger general practice and they send more pituitary adenomas than we see. So we have very good neurosurgeons whom we have a lot of confidence in. So we always prefer them to go in and decompress the optic apparatus if required.
The next question is optic constraints for fractionated SRS.
So your guess is as good as mine, to be honest. Something like I said, the data is very immature. If you go and see the data on fractionated SRS, you will actually see reports of individual cases. Okay, so if you, let's say you want to use a 25/5, actually you can give the full dose to the chiasm, but I would imagine you restrict the optic nerve to 95% of the dose and you should be okay.
Is there a difference between the time to endocrine response when comparing fractionated RT versus SRS?
So I think I have mentioned this clearly. There's a much steeper fall with radiosurgery, but once you reach a certain time point, let's say 5 years, the biochemical failure-free survival becomes pretty much similar. And in our experience, actually, it is better for us with fractionated RT than the radiosurgery we see in literature.
Okay, so any other question from anyone? Okay, so when you treat a little bit advanced pituitary tumor involving cavernous sinus or extending to temporal lobe, then how frequently do you encounter neurological complications arising out of radiation to cavernous sinus?
Very little. So hardly any. Actually, we see those cavernous sinus entrapment neuropathies with other tumors, so pituitary tumors, if you ask your neurosurgeon when they go in, it's like they open the sphenoid and the tumor falls out like a fine powder, okay? And the capsule sort of collapses in on itself. So I don't think the local desmoplastic reactions elicited when you have, this is pure conjecture, of course, the reactions elicited are that severe to cause those entrapment neuropathies. We do see them in other cellular, supracellular tumors to a greater extent. But that being said, we don't really very carefully ask for third, fourth, and sixth nerve symptoms on our follow-up, and subtle neuropathies are very liable to be missed.
Should hypothalamus be given any dose constraint?
So that's again, we have published this. I mean, it's 27 gray if you can restrict, which is very easily done. But with significant supracellular extension and all, it is difficult to do. But thing is, in a pituitary tumor, if you try to reduce hypothalamic doses, you should be very careful. See, you can always, the thing is, you don't want to be faced with a relapse because of a marginal miss in pituitary tumors. I mean, that means that you've not really done a great job most of the time.
So, what is the usual time sequence when you expect no more or no further reduction of residual tumor size after radiation in a fractionated way?
We hardly see any reduction most of the time. So most of the time it is static. Some of the time it is a little bit of shrinkage. So typically what we do is we get the MR at 3 months. And if there is no further symptomatic progression, we repeat only an annual MRI. And most of the time it is static. Okay.
How do you control it on a T1 contrast MRI or any other MRI sequence?
So thank you for the question. So typically what we use is a thin cut axial 3D FSPGR. And additionally, we may also use a T2 or a T2 flare sequence if it's like a big tumor with sphenoid extension and all, for us to see those inspissated secretions and all well. Also, there is a role for dynamic imaging where you have, but though we don't directly use it for planning, it enables you to make out the tumor well because of its washout characteristics vis-a-vis. So what you will typically see is a lot of fat packing and gel foam packing and all, and you're not supposed to take any of that in your GTV. And the thing is, that will be bright on the plain T1. So it's a very typical mistake which people make, and with time you learn how to leave all of that out. I mean, when you see a 30 cc CTV initial or a GTV in a pituitary tumor, in which good surgeries happen, most of the time there is an error in contouring.
So the next question is, any experience about pituitary carcinoma and a role of temozolomide?
So the only pituitary carcinomas which I can recall in the recent past, they did not even, they were so bad they did not even come up for radiation. So, but yes, there is data on atypical recurrent carcinomas with temozolomide. And there is data for pituitary carcinoma also, but thing is, temozolomide is an intracranial panacea. You can use it for anything, and it is not particularly great at treating anything either. So maybe you will get a marginal benefit. There is data, yes, but it is quite limited. More data is there for atypical adenomas and recurrent adenomas than frank carcinoma. But I would not recommend temozolomide being used concurrently outside the context of a trial. It is not really standard of care.
Interesting thing, what I was noticing, I might be wrong because I have not seen the patient clinically. The planning picture you have shown comparing different techniques, it looks like the person had prognathism. Now,
so that will
do you or can the patient expect in resolving all these changes in the body, like
so,
finger size, like
yes, the soft tissue edema.
What is the usual time course of having or achieving those resolutions?
Achieving is difficult to say because they are very dynamic, and thing is, a lot of them start to fail also. But typically you will start, if things have worked, you will start seeing that reduction of acromegalic features and Cushingoid features when you call them at 3 months. So between 3 to and we call them 6 monthly thereafter, right? So around a year, a lot of patients would have had a lot of regression, but the prognathism and all is usually long standing, that prognathism and frontal bossing and all is not going to go down. But the sausage-shaped digits and the coarse facial features overall do resolve to a certain extent. And if you see Cushing's, actually it is more common in young women. Typically, they are quite even so a lot of there'll be young gentlemen and ladies who have like plans for marriage and this and all, and a lot of that actually there are lots of social disruptions in these patients' lives if you talk to them consequent to their disease. And when these obvious facial features resolve, it creates a lot of it boosts their confidence greatly, and it has a huge impact on their social well-being and quality of life. Yeah.
Great. So then last question probably, is neck flexion while positioning still relevant to reduce eye or lens dose in IMRT or SRS era? Can neutral position be used?
It is good too, but it is inconvenient actually. If you do work on a lot of your systems, actually you will have a lot of problem taking the imaging once you do that flexion and raise that isocenter height. Something which you will, unless you have a very exotic position for your isocenter. And moreover, it is not necessary. Thirdly, at least the eye doses are never a problem when your overall dose is 45 gray. But at least our experience, what I can say with lens doses is in IMRT, they are more or less exceeded all the time. That's not something which we can really control. Even when if you use an avoidance sector or a directional block, because the newest thresholds for inciting cataractogenesis are so low, you may not be able to control any of those.
Very true. So I think regarding cataract, it's best to counsel the patient about the probability of having cataract surgery in future. So any further question from anyone? All right, Dr. Abhishek, I think we have reached the end of the session, and I sincerely thank you once again for your nice lecture and enlightening us on this beautiful topic. So with this, I would like to end today's session. And once again, thank you for your time, and thank you everyone for joining in.
Thank you very much. Good night.
Good night, and good night, everyone.